I just remembered something actually regarding genetic testing. I remember when I moved to UT like 5 years back, we had a patient who really forced me because there was a strong family history. And I called the genetics clinic. I wanted to talk to the physician, and some reason they directed me to the office manager. And she said, okay, hello, I want to refer a patient to get a genetic evaluation done for pulmonary fibrosis. The first question she asked me is, how old is the child?
Yeah.
I'm like, he's not a child. He's like 52 years old. So you can imagine there's a lot of work which still needs to be done, and it took us almost 1.5 years to set up a process to get genetics counseling done for all the patients who come in. And thank you very much. It was very enlightening. And I'm sure you guys have a lot of questions, so feel free and go ahead. Go ahead.
DNA changed for about a year and then reverted back. Can you comment on that?
You want to use the mic?
That's a really interesting question, and so far that is the only instance that sort of that has been studied in. But there were that was a very interesting story, right? So there were a whole number of things that seemed to change in that one twin over the course of a year, that after being back in space, where after being back on the ground for a year reverted back. And one of those things was telomere length, but there were others, things around bone density and other tests and things like that. So I look at that as a sign that there is opportunity for recovery, and that changes are not necessary in certain circumstances. Just because something has changed doesn't mean that that's permanent, that we are more plastic and more malleable than we may have realized. And I think there's increasing recognition of that in many spectrums of medicine right now. That was a fascinating, it is.
Mm-hmm. Yeah, there's still so much we don't know and don't understand. I just read an article online about, there's a phenomenon called uniparental disomy, where it's a rescue mechanism in our DNA, and all we know about it so far is that in some cases it can lead to disease. But with all the people doing 23andMe, some researchers studied it, and it's vastly more common than they thought. I don't know if you saw that.
So what that means is normally you inherit one copy of a gene from each parent. In this case, something gets messed up when you're developing as an embryo, and you get 2 copies of a gene from a single parent. And yeah, our understanding of how that works is clearly far from complete.
And please do wait for the microphone. There's a microphone, and if the questions aren't on the microphone, they won't be recorded for people who want to listen to this later. So I'll bring the microphone around to you. We have a question over here.
I actually have 2 basically simple questions. My mother died of IPF. My sister Sally has IPF. She just is at 5 years. Should I go have a lung something? I mean, my doctor said, there's no crackling. You have no reason to do that. I'm just wondering if I should. And my mom's first cousin died 2 years after my mom died. So it seems to be a lot.
I'll let you do that. You're a doctor.
So,
well, you spoke of early intervention, so I'm just wondering.
So what I counsel people when I see people like you in clinic is that I do think that some sort of screening is wise in people who have a strong family history, and I encourage them to do it because we admittedly, we don't know when to start, we don't know how often to do it, to if it is something that they could be a part of one of these research studies, to do it in the context of one of these research studies. But I think we clearly, we need to understand when and how to do it. And I think something that I'd like to emphasize on that front is I think that there are some people in the community who are probably advocating people to get scanned way more frequently than really is necessary or helpful. Like, based on what we've learned in our study over the course of the last number of years, if someone has mild changes, they shouldn't get another scan in 3 months. We know there's marginal change over the course of years. So I think that the horizon, we need to take a long view with this, but it isn't the same as if, for example, someone has a spot or a nodule in their lung and they need to get followed very closely. The time frame on this is probably more spread out. So if my general guideline and the general approach that we use is to say, if you're somewhere around 50 or, say 5 years younger than the youngest person in your family was when they were diagnosed, that's probably a reasonable time to do it, but that is opinion. That's not guidelines, that's not recommendation, that's opinion. Yeah.
And I punted it to him because he's a physician and I'm not. So I'm never going to tell someone they should go have a CT scan, but there's risk for CTs, right? It's radiation to your chest. So, and like Dr. Kropski mentioned, if you overdo that, then you might have other problems that show up and you're just trading one thing for another. But I had a question once with a family member who did a CT scan and say they were 65 and there was no fibrosis. It was inferred that they don't have to worry about it. What do you think of that?
So I think that we need to really understand if that person actually is at no greater risk than anyone else or not. I can say that, again, I don't want to over-extrapolate small numbers, but it does seem that if someone doesn't have changes by their mid-60s, it is uncommon but not unprecedented for them to develop at least mild changes and develop pulmonary fibrosis later. There are patients that I take care of who are in families who, maybe 75 and have this is the first time they've had very mild changes. Their lung function is normal and they don't have any significant symptoms related to this. And so those people, we check in, once a year, and if something changes, we get new scans, but we sort of check in once a year and tend to follow lung function tests.
I'm sorry, I'm starting to ask questions now. Would I'm losing my mind today. The finger, when they measure the oxygen from the finger. Pulse ox. Would that be something to keep an eye on?
It's probably not sensitive enough because I think it's an easy thing to do, but I think we know that people have to lose in most cases, they have to lose a significant amount of lung function before they'll detect oxygen abnormalities. And so I think all would rather detect disease earlier in people, especially. I think this is just a very different conversation than it was 5 years ago when we didn't have any effective therapies. Now that we do, I think that there's a lot of reason to try to make early diagnoses.
So I have a kind of a response to that also. I'm the fourth member of my family that was diagnosed with IPF, my brother, my sister, and my mother. So my mother and my brother died in 2002 and 2003, and my sister and I immediately went in. Back then it was just a lung x-ray just to see, to get a baseline. And then when she was diagnosed in 06 or 07, I started going in for periodic baseline pulmonary function tests. And it wasn't until I had a sudden drop that then I was diagnosed. And that's when I had my first CT scan to kind of solidify, that was what it was. So I was detected very, very early. And actually, I have no crackling, and I wouldn't be going to the doctor if I didn't have that family history, because I just feel like I'm getting older and out of shape, and so it's harder to climb the steps. So I do think it's important, if there is a family history, to get those baselines.
For those of us who are trying to follow the research, well, we have about 10 genes that have been identified, and like several of them express themselves affecting the telomere ends. How specific is the research? Like if we see something on a variant, not our gene, that is in the direction of improving telomere end results, can we assume that might apply to us, or is it pretty much the research needs to be on your gene to have meaning for you?
That's also a wonderful question. And I think I'm interested in Janet's perspective too, but I think it depends. It's probably, there are certain things that are, certain genes probably do the same thing in all cells, but certain genes do different things in different cells in different contexts. And so I think that the likely answer is it might. I think it's certainly something that we should use that information to try to understand whether or not it applies to the lung, and it might not.
Mm-hmm. And if I'm understanding your question, if you read about a new gene for pulmonary fibrosis, should you be evaluated for it? Is that kind of what you were?
I wasn't asking that, but that's a good question.
I think that's when genetics comes in and determines if you're a good candidate for that gene. I think, the familial, the family history, with the families with the history of it are really going to enrich for finding a gene mutation more so than a sporadic type family history. So the more check boxes you have for leading to a gene mutation, the more likely we're going to find one. Mm-hmm.
Is the announcement last week with cystic fibrosis, that may have any implications for our community?
That's a very good question, actually. That's like comparing apples and oranges. So the mutation in it is completely different. And to put it in context to what we are talking about, especially when you bought telomerase, but again, remember, telomerase is related to aging in general. And if you look at the clinical context on it, we know excellent studies, if you have a shorter telomere, you have actually increased risk of death. That can be just not from pulmonary fibrosis. That can be other things too. And again, a single mutation is a big challenge. We still don't know a lot. To put in perspective, I think I listened to Dr. Garcia's grand round when I was a first-year fellow in 2007. And from that time to now, she has become a professor, but she has published so many different new genes which have come into it. And that's a span of 12 years. So it's a very emerging field as of right now, what we are learning. And then it's actually, we just have to tune ourselves and look forward.
Yes, as a causative IPF factors exposure to mold in birds, does that impact genes and chromosomal changes to initiate IPF?
On the same note before, that's the same question I want to ask you, because I come from Houston. As you know, it's a Permian basin. Our air quality is probably one of the best in the whole world. We do see a lot of people, a lot of exposure to mold industry. They worked on farms. They worked on different factories with asbestos exposure, welding, this and that. So how do you tie that all down, especially in the context of genetic exposure?
Okay. So our DNA is under siege from the time we're born. And what we call somatic mutations are mutations local to an organ that happen from exposures, either within our bodies or outside of our bodies. So as we age, we accumulate mutations in our genes too, but they're coming from an outside source. We weren't born with them. So what we've been talking about mostly today are inherited type gene mutations, but definitely exposures can change our DNA. We've seen with, on a cellular level, individual cells being attacked, and we have a built-in protective system to kill off cells. Like in cancer, what happens is it's an accumulation of mutations, like what Dr. Perez mentioned today. Like cancer's always genetic, but it's not always inherited. So our genes try to repair themselves, but if they can't, they kill it off. But sometimes in cancer, those mutations go unchecked. With pulmonary fibrosis, what I imagine is you breathe things in, the exposures to birds, mold, pollution, whatever, goes in, and it's actually changing the DNA of the cells local in the lung, but it's not something that you can pass down. So I'll say that.
So I guess just to piggyback on that, that is something that is, I think, very interesting and something there's a lot of active work trying to understand if that happens, but we know clearly that you accumulate somatic mutations, but we haven't yet understood whether that happens and specifically drives disease in the lung. I think the other way that this may play a role is that many of the genes that have been linked to disease are things that seem like they impact your lung's ability to repair itself. So it may matter less about what the specific injury or stimulus is, and just matter that there is one. And it could be mold, it could be birds, it could be asbestos, it could be silica dust, it could be a lot of things. And just some folks carry things that make them programmed to respond differently and to respond and develop fibrosis, whereas others heal that injury and shut that process off. So I think both of those things probably play some role.
Technically, would that be IPF and not just PF? Excuse me. Technically, wouldn't that not be IPF, but it would be another form of pulmonary fibrosis?
That is how we make these classifications currently, but I think that that way of thinking about things is, as we learn more that the same genes seem to be associated with risk across all these different exposures and different types of disease, that might not be the right way of thinking about things. That is the way we've done it historically, but I think that, as has really been discussed a lot here, I hope that next time we have a PFF Summit, we're really talking about types of disease that are people who have diseases that behave the same way, rather than just may look the same on slides or had a similar exposure.
I'm sure there are a lot more questions. I think it's time to close down. A couple of housekeeping things. So please remember to visit the exhibitors at Cibolo Ballroom. Anybody who's Facebook and Twitter active, please use our icons available in the Summit program book. And we just have 60 more minutes for the cocktail hour. And there are actually therapy animals there, somebody who needs some canine love, and we have dinner at 7 o'clock. And if you're a respiratory therapist, please register sign the conference at the front desk so you can get a CE credit for it. And thank you very much, actually.